Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral, extremely occluding and impacted earwax. It was quite a tricky procedure. We're just commencing with this there right ear first. You may have noticed this patient has a small nodule, a rubbery nodule, just at the roof of the entrance of the ear canal, and we call that a keloid. So a keloid is a nodule, a rubbery, fibrous tissue-filled nodule that typically occurs after trauma to the ear, so a wound or a puncture of the skin. In fact, it's quite common after ear piercings if they go wrong. This patient hasn't had an ear piercing, but they did say they had trauma to the ear many years ago. The keloid is not causing them any problems whatsoever. Just some dried wax. I did clean that up at the end of the procedure. It's just in the conchal folds. That's part of the pinna, the satellite dish on either side of our ears. There's just a bit of wax in there. So it's really impacted this. I've just instilled some medical grade olive oil spray. And what the olive oil spray tends to do is binds this soft, mushy wax together, and it just makes it a bit easier to remove. You can see the periphery of this occlusion. There's a lot of dead skin, keratin. It's enveloped itself. That's that glossy, almost translucent sheath of skin that we can see. I've just instilled some more olive oil. Now, the great difficulty I had here was that it was very difficult to position the endoscope exactly where I wanted it in the ear, because the outer third of the ear canal, the cartilage portion, was quite rigid, more rigid than usual. And normally I'd go into the ear, I'd push the endoscope to the left, in the case of the right ear, and you can see the endoscope's more central here. And when you put the instrument in at the same time, it can be a bit crowded in there. So it's not normally an issue. So to overcome that, a bit later on in the procedure, when I'm beginning to remove wax from the anterior and inferior recess, they've got quite a prominent anterior and inferior recess, I used the new zoom function that we've installed onto the new ClearWax app, which is in the final stages of development now. And what the zoom feature did, it does reduce a bit of clarity, unfortunately. Now, the iClearScope system, we're using the iPhone SE, the third generation. The reason for that is that it's lightweight and not too large. And of course, it's affordable. So when we're selling this on a commercial scale, we want to make sure, of course, it's of a very high quality, but also affordable. So there are other iPhones, of course, you can use with superior cameras, but the iPhone SE is more than adequate for performing earwax removal and also diagnostics. So when you zoom in, the image does get slightly grainy, but it did help me a lot. And the reason why it helped me a lot, because it didn't require me to over-insert the endoscope. I could just have the endoscope more lateral near the entrance and zoom in and still have enough access to remove this wax with the instrument. As you can see, I'm really filling this ear with the olive oil spray because of the consistency of this wax. It's so mushy. And as we approach the eardrum, the ear canal narrows. You can probably see that on screen. I'm using the full Zollner at the moment, so there's not much manoeuvrability available, and I've just got to be careful I don't catch the anterior canal wall with the Zollner. The front section of the ear canal is coming very close. At the moment, the fine end just wouldn't be powerful enough. It will get blocked. So I'm just going to try and remove a bit more, and to allow better access. You can see I've zoomed in a little bit now. So the zoom feature I initially developed to work alongside the wax scope, because the wax scope will benefit from having the zoom feature, but in this case it also became handy when using the iClearScope. So I'm just going to zoom in again, and I think now I'm still using, it's very difficult to tell what I'm using now because I'm zoomed in. I think this is actually a fine end, and this wax, it's very mushy, it's trapped in the anterior recess. So as we approach the eardrum, the ear canal narrows and then it widens again. And it normally widens anteriorly to the front section of the ear canal, and it creates a recess there where you can see all this sticky wax, and also at the base of the ear canal it widens towards the floor of the ear canal, and you get another recess which we call the inferior recess, and it's very difficult to remove wax and keratin from there. In fact, if I was using a microscope or even the wax scope, it may not always even be visible. This is why an endoscope is so good for earwax removal, because it provides this wide panoramic field of view. You can get access and visibility of the whole ear canal, even in the small crevices that may lurk within the ear. So you can see I've got a much better angle now. We can see the majority of the eardrum, but I just want to peel away as much of this debris as possible. Again, just use some more olive oil spray. And you will see it in a moment. I've really had to bend the fine end. So I think there's a small bend here at the moment, but it wasn't suffice, and I had to bend it almost to a 40 or 50 degree angle to really get inside the recess. Once again, want to try and avoid making contact with the front section of the ear canal. We are quite close there, and I think it's at this point where I decided to just bend it a little bit more. We shall see. Okay, not quite yet, but oh no, there we are. So by bending it a little bit more, you can see I'm further away now from the anterior recess. I'm far less likely to make contact. In fact, I think it's impossible for me to make contact with the anterior canal wall other than with the tip of the suction probe as I'm entering. You've got to be careful you don't overbend it, because if you do, you can constrict the inside of the suction probe, so you can kind of seal it off. So again, I'm just going more inferiorly now. And there's a possibility this may naturally migrate, but because it's such a deep recess, there's also an equal possibility that it doesn't. So the patient was comfortable. I felt confident removing this, so I decided to continue. I'm going to peel downwards in a moment. Now, by introducing a bend, it did reduce the suction power slightly, because obviously the airflow it has to be rechanneled around the bends. In fact, I don't think I've ever had to bend the fine end as much as I have here. It does make inserting and removing the fine end a bit more difficult when you've got a bend so prominent, because you can easily catch the front or the rear of the ear canal as you're going in or taking it out. So slowly it's coming away. There is going to be some residual wax there. I'm not going to try and get everything out. I just want to get the big lumps out. And some of it's just staining. When you've got wet sticky wax like this, and it's compressed against the eardrum or the ear canal, as you remove it, you're going to get some residual staining. Now, it was such a severe impaction that this patient couldn't, let alone hear the suction noise in the ear, they couldn't also hear the suction machine until I removed the wax. So it must be quite considerable severity and level of deafness this patient was experiencing. The suction probe in the ear can, with the full Zollner suction probe, it can at times peak at 110 decibels. Now, in the mainstay, it's going to be hovering around the 80 to 90 decibel mark, which is quite loud. But they weren't able to hear it at all when I began the procedure. So you can just imagine the improvement this made to the patient. So we're nearing completion here. Just a little bit on the anterior superior portion of the eardrum and anterior canal wall. So just going to hover over. Truth, I probably should have just left that. Wasn't going to cause any mischief. So I'm just mopping up near the entrance. I am going to go back inferiorly in the patient's eardrum because there was a bit of oil there that had collected, so I wanted to clear that. I've just zoomed back out. This is the normal magnification level. So this is the entrance of their ear. And there's that keloid that I made reference to before. What do you do with a keloid? Unless it's causing any harm, you would just leave that, so patient not causing the patient any difficulties or problems whatsoever. Sometimes there is, I think, laser surgery to remove that, which is performed by ENT. So it's a bit oily in this region here, so I'm just going to try and clear some of that up. So it's at the basin of the ear canal near the eardrum. So it's very likely if this patient gets water in the ear, it will get trapped because of these recesses, these quite prominent recesses that he has. So I'm happy with that. Yes, there's a bit of staining here and there, but that's fine. That's not going to cause the patient any problems whatsoever. So we're going to move on now to the left side. Similarly to the right ear, the left cartilage was quite tender on this side. It was, again, rigid. Now, the patient did report rubbing this ear quite a lot, which is probably the main cause behind the tenderness of their cartilage. Sometimes patients can suffer from cellulitis of the cartilage, also known as perichondritis, so that does need treatment if so. It can lead to a cauliflower or wrestler's ear, I think it's called in America. So I'm just mopping up the entrance first. Again, I'm going to use quite a lot of olive oil during the procedure. At present, because of the location of the wax, I'm not entirely sure of where the back part of the ear canal is, so I've got to be careful when I'm inserting the suction probe and lifting it away posteriorly from the back part, because I don't want to bump in accidentally to the canal wall. I just want to see a bit of flesh there now. I can see that the floor of the ear canal, and I can see some skin adhesions appearing. So I know that the ear canal is in close proximity. But once I can see the back part of the ear canal, I then have full confidence in where to insert the instrument and where not to insert the instrument, more importantly. It's quite a dense plug, this. You can see it's not as occluding as the right side. There is a bit of a gap there at the roof of the ear canal for a bit of sound to go through. So I'm just going to focus on the back wall of the ear canal. Just want to gently peel away this wax to see the canal. So I'm getting to get an idea of the anatomy now, which is really, really important. So this patient's ear canal, as opposed to being oval shaped, so most of our ear canals, they're not round. They're not circular. They're oval shaped. The height is greater than the width. So like an American football or an egg. But in this patient, the anatomy on both sides, but more so the left side, is very circular, very round. You can see just like the right side, they've got this layer of skin that's enveloped the wax plug and is still adhered to the canal wall. There's a few hairs in the wax plug as well that have matted. You can see some of these here when I'm removing the wax with the suction probe, some of the hairs that are visible. So I'm just going all the way around, just trying to lift it off the canal wall as much as I can just to retract it. Now, I wouldn't glide in with the right correct here because we're on the bony part, so unless it's absolutely necessary, I wouldn't want to do that. If it's more lateral near the entrance, that's fine. So I'm just going to persist with the suction. When you've got dead skin like this, you can see how stretchy and elastic it is. It really does pull when you perform microsuction. So I think I'm going to put some more olive oil spray in there. You've got to be careful when you've got dead skin like that because it can sometimes clarinet. Clarinetting is when you suction dead skin, the dead skin violently flaps at the tip of the suction probe. And when it does, it emits a very loud, high-frequency squeal. It's not only loud for the patient, it's loud for myself. So you have to bear that in mind. Whenever you do get clarinetting, of course, you should stop the procedure and try to revert to a fine end if possible. But obviously, if the patient's got clarinetting now, fine end isn't really going to help in this situation. There's too much wax, it's too dense. You can try and use a different instrument, you can reduce the suction power. You can also try and position the suction probe in such a way that you embed it more into the wax and your movements are slower. And that can sometimes also help to reduce clarinetting. The problem with this wax, if you try to embed the suction probe a bit more into the wax, because of the consistency, you can easily block it. So I'm just trying to kiss the surface here. I want to avoid the suction probe getting blocked. And you can see I'm just gently trying to bring forward the more medial wax and slowly rocking it forwards. And here we are. It's got trapped at the entrance. I think the suction probe actually got blocked there, so I'm also using the suction probe as a scoop there to remove that last piece. I'm just going to mop up some of the residual wax. So there's some wax on the anterior canal wall. It was quite tricky once more to stretch open the patient's ear because the cartilage was a bit more rigid than usual. So just got to avoid touching that canal wall. I think I'm using the full Zollner there. The eardrum, you may have noticed, appears slightly retracted. The top part of the hammer bone, which we call the short process, the other name is also the lateral process, is the circular, spherical aspect of the hammer bone. It's somewhat protruding forwards, and then the eardrum on top of it and the pars flaccida, also known as the attic, it looks like it's draped over it, so it's sucked in superiorly. The eardrum, if it's sucked inwards due to negative middle ear pressure, you can get a retraction of the pars tensor. So the eardrum, there's two sections of the eardrum, the main body of the eardrum, so anything below that short process of the hammer bone, so that spherical pointy part that's protruding towards us, anything below that, we call that the pars tensor. So that the main body of the eardrum, the pars tensor, is a bit more tense, a bit stronger, hence the name. And anything above that short process, we call that the pars flaccida. So it's more flaccid. It's thinner in the respect that the eardrum has three layers. The outer layer is made up of epithelial skin cells. So it forms the epidermis layer, the same skin that lines the ear canal itself. The innermost layer is made up of the mucosal skin that lines the middle ear, and think about the mucosal skin similar to the skin inside your nose. So it's more moist, secretory, it can produce mucus. And then you've got a middle layer made up of fibrous tissue. Now, the fibrous tissue in the pars tensor, it's aligned radially and concentrically, so it gives more rigidity to the pars tensor, whereas in the pars flaccida, the fibrous tissue is more diffuse, so it gives less strength and body to the pars flaccida. Hence why, if ever there's negative pressure in the middle ear, or if, for example, you're in an aircraft and you're descending, the cabin air pressure will push your eardrum inwards. Or if you've got a blocked eustachian tube, which is the pressure equalizing tube which connects the middle ear to the back of the nose, if that's blocked and there's no air able to enter the middle ear and all the remaining air in the middle ear gets absorbed by the cells in the middle ear, it creates negative pressure and then your eardrum gets sucked inwards. And because the pars flaccida is more thinner or less rigid and strong, less tense than the remainder of the eardrum, it's more likely to get sucked in. You can still get a retraction of the pars tensor though, so it's not unfeasible. It's quite, I would say, of course, most retractions are attic pars flaccida retractions, but I do see quite a few pars tensor retractions as well. So I'm just mopping up near the entrance. Again, there's going to be a bit of wax here and there. It's a soft, sticky type of wax. It's just residual staining of wax. I put a lot of oil in there. It's just a bit here on the border of the cartilage and bone, so I'm just going to glide over it with the new Raithatha, trying to get any excess oil and wax out. I'm sorry guys if the narration's a bit stop-start. I've still got quite a bad throat, so I am having to pause the narration and have a little break and return back to it. So hopefully it all combines together, all the passages of narration. So I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.